This is the simple way of asking your patient, what is his functional capacity? Can you take up care of yourself? That is one met. That is eat, dress, or use the toilet, walk indoors inside the house. If he can walk a block or two on a level ground at around 2 or 3 miles an hour, which is like a leisurely walk, it is around 3 mets. If he can do light work around the house like washing dishes, it is around 3.5 mets. And that is how it goes. 4 mets on climb a flight of stairs or walk up a hill, do a heavy work around the house like scrubbing floors, lifting, moving heavy furniture, etc., etc. That is around 6 mets. More down the line, if you go 7, 8, and 10 mets. What I'm saying is, every patient coming to you may not have a stress test done, isn't it? They don't have a stress test with them. In fact, 90% of them. So what level of functional capacity do you judge? You just ask these simple, very, very simple, straightforward questions. And you will know, any functional capacity of 7 metabolic equivalents and above is a safe, relatively safe patient. Because he will stand the stress of surgery, because even intermediate risk surgeries do not produce a metabolic stress of more than 7 mets. Only vascular surgeries, neurosurgeries, major cardiac surgeries, abdominal aortic aneurysms, bilateral TKR or THR, these are the kind of surgeries which produce a stress or metabolic stress of something like 8.5 mets. So if you have a patient who can do 7 mets approximately, you have a safe patient. And then there are high risk surgeries, intermediate risk, and low. So these are the procedures which are kind of high risk, intermediate risk, and low risk procedures, which I'm sure all of you have these charts with you all the time, so that you can equate the risk of a patient on one side and the risk of the surgery which is going to go through on the other side. And you have to balance this. There are some tests which improve the identification of definition of cardiovascular disorder. And I'm sure all of you all do this: resting 2D echo with Doppler, routine treadmill stress tests, in some indicated cases, dobutamine stress echo or adenosine stress thallium, and 24-hour ambulatory ECG for those patients with arrhythmias. These are the 5 fundamental, easily available, ubiquitously available tests. Most of the centers have this, which should be done in indicated patients. I would believe that a resting 2D echo Doppler should be done in every elderly patient with vascular risk factors. And of course, we'll talk about this when we start the cases. Okay. Bala will start the first case scenario.
Before that, I just want to, for benefit of all of us, want to ask you regarding when we discussed on the blood pressure, we thought if it's an elective procedure, it's best to have 140/90. In few conditions, especially in the geriatric population, we have the isolated systolic hypertension of the elderly, and especially when they cross 80s. So what do you think should be our criteria in this age group?
That's a good question you just brought. Actually, all of us tended to believe at one point that elderlies they do have isolated systolic hypertension, and they may be left with that blood pressure, which is not true. SHEP trial, elderly trial, HOT trial, and HOT2 trial all have proven that even in elderlies who are going for a major non-cardiac surgery, the systolic has to be maintained below 140 pre-op. That is the best bet that perioperative myocardial ischemia doesn't. This I'm talking in context of coronary disease, to avoid the perioperative myocardial ischemia. So there is no such separate cutoff limit for the elderly.
Okay, so that's a very valid point, because if they come with a pressure of 200 by 90 or 200 by 80, if we go by the textbook descriptions that we need to get the systolic less than 30% of the preoperative level, and it becomes like still it will be more than 140. So that's why I thought we should clarify this point from the cardiology point of view. And I think now it's very clear that in spite of the age, in spite of the isolated systolic hypertension of the elderly, it's best to try to achieve 140/90 in all the age population. Majority of the patients. The second question which I would like to ask before we be going into the case scenario is, many times, especially in trauma, in geriatric trauma, considering that's one of the commonest, in this geriatric age group, apart from myocardial infarction and malignancy, the commonest thing that they come to the hospital is after a fall and having a hip fracture. What happens is, in these patients, they come with very high pressures because of the pain that is associated with that. So one of the things which I wanted to bring for discussion is when you see an isolated one reading of blood pressure of 200 by 100, and suppose if you take like in the presence of pain, any antihypertensives takes a very long time to get the pressures down. What do you think about the concept of, for example, if they have a hip fracture, on arrival you give a femoral block, and you get because once the patient's pain relief is there, you get the pressures down. And invariably we see that after a block and when the VAS score becomes less, the pressures also come down. The sympathetic overactivity is less. So do you think that it could be advocated that instead of just relying on one blood pressure and postponing the case, do you think it will be a good idea to give a pain relief, which is very good, check the pressures again, and then try to take this patient as early as possible for a surgical procedure in this group of patients?
Sure, absolutely. See, geriatric patients who come with, let us say, fracture neck femur with a accidental fall in the bathroom or something like that, there are a lot of factors which play. Pain is the most important parameter. Second is the anxiety of coming to the hospital. They may not have seen the hospital ever there in their life, And then these two factors increase the blood pressure. So in the olden days, we used to talk about post-operative analgesia. Now we talk about peri-operative analgesia. So you start with pre-operative analgesia, relieve anxiety, and this itself you will achieve some 30-40 millimeters of systolic drop in blood pressure. And then 3 or 4 hours down the line, you will find the patient relatively very safe and stable to be wheeled into the theatre. That's very, very, very correct. Absolutely.
Yeah. So that's one thing which we want to clearly define, because in a day-to-day practice, we should never postpone a case just by one recording and saying that cardiology opinion, physician's opinion, and just wash away the hands. I think we need to go one step further, because eventually we want this patient to go home. It's our baby. I think the day we decide that every patient is our patient and it's not the surgeon's patient, there is this small shift in the attitude makes a huge difference in the outcome.
So can we start?
Yeah, we'll start the case. Yeah.
This is a case scenario. This is one of our orthopedic surgeon's patients. 64-year-old female, diabetic for the last 6 years. History of anteroseptal myocardial infarction 3 years ago, was treated conservatively because of age. She has class 2 very stable angina, but she can do most of the domestic activities very well, including washing dishes at times. So she is met in terms of MET, she's around 6 METs, activities very without angina. Canadian Cardiovascular Society class 2 as we call it. Echo shows an ejection fraction of 40% with type 2B diastolic dysfunction. She's taking aspirin, ramipril, and monotrate. And now is diagnosed to have fracture neck femur. Now this is the case scenario. I asked the audience after this, what do you make out of this case scenario? What do you think? What are the catch points here? Look at this. What do you read out of this data available? She can have triple vessel coronary artery disease underneath because she has never been studied. She was treated conservatively. She is a diabetic, remember, and who has a myocardial infarction at the age of 61. She's 64 now. So obviously, she could have a triple vessel disease. She has type 2 diastolic dysfunction, meaning there's a poor margin, very poor margin to give fluids, volume. Somebody in the audience was, yes, you're there, asking me yesterday, what does the diastolic dysfunction mean? Type 1 is safe. Type 1 is almost all elderly people will have. Type 2 and B is an unsafe type where the rapid volume you give, they'll end up in pulmonary edema. Elderly and diabetic are 2 words that translate into poor renal functional reserve. Please remember that. And she is not taking established drugs that reduce cardiovascular risk in non-cardiac surgery, like she is not on beta blockers and she is not on statins. Having said that, strategies to reduce cardiac risk in patients with CAD are coronary revascularization pre-op, choice of anesthesia, and maintenance of intraoperative hemodynamics and normothermia, which Dr. Bala will enlighten us upon, perioperative pharmacotherapy with beta blockers, statins, and alpha agonists, excellent perioperative analgesia. Now the question to me, or from most of the surgeons will ask, is whether you would like to revascularize this patient pre-op. Now look, here is an elderly lady who has fallen down, has a fractured neck femur. Let us see the ACC indications of revascularizations. ACC indications are, it is a must before are indicated in patients who have stable angina, patients who have significant left main disease, 3-vessel disease, or 2-vessel disease with proximal LAD involvement. Now, do we have the data in this patient? We don't have this data in this patient. And it is not recommended, revascularization is not recommended as a routine prophylactic revascularization in patients with stable angina who are going for non-cardiac surgery without the previous parameters, right? Without this kind of disease. So now what we need is probably, should we do a non-invasive testing? That's the next question. Will you like to do any non-invasive testing in this patient pre-op to surgery? Now, can I ask the audience, which is the best non-invasive testing? Let us see. Let us take an opinion poll. A dobutamine stress echo, that's a great answer. Any other answer? Cardiac CT angio, next, very good answer. Anything else? Sorry? Thallium scan. So there are 3 answers which are quite reasonably well spaced. Let me put it this way. Let us talk about CT angio. CT angio gives you an information which is of structural information. We don't want structural information here. We want functional information prior to structural information. We want to know whether she can stand the stress of surgery. And here, either adenosine stress thallium or a dobutamine stress echo would be a very good. So now, non-invasive testing is recommended in patients with at least 2 clinical risk factors who have poor functional capacity. What did I say about the functional capacity of this patient? 6.5 mets. So I'm just going step by step to tell you that this patient, in my opinion, does not require a preoperative non-invasive evaluation. She has an old stable infarct. She's getting class 2 angina. She can at times wash dishes, do all her domestic activities without angina. Once in a while, she goes out also without a problem. So here is a patient who can stand through probably a fracture neck surgery without a problem. But then, had she had a functional capacity of less than 4 mets? Yes, of course. Then this is a beautiful study published in JAMA 2001. And another study which has appeared, I will show you in one of my next cases in 2007, which tells you that there's a fountain here. Okay. Now, if you can see on this side, you have a determined risk score. Assign 1.2, age more than 70, current angina, prior MI, congestive heart failure, severe events, diabetes, and renal failure. How many points we have here? How many points we have here? No. We have 3 points. Current angina, prior MI, diabetes. We have 3 points. We have 3 score here. So 0 to score 3 falls a low risk category patient. There is no need really. There is no need really of going anything further. Let us see if we give a score of 4, more than 3. Then you do dobutamine stress echo. If there is no new wall motion abnormality, proceed with surgery because the event rate is very low. And across the board, whether you have wall motion or new wall motion abnormalities more than 1 to 4 segments, from low risk, intermediate risk to moderately high risk. When you are on beta blockers, that is this light blue bars, beta blocker use, the event rates are less. And no beta blocker use, the event rates are high. And very high risk patients, whether beta blocker or no beta blocker, event rates are same. They need desperately revascularization pre-op. So this is the message of this slide. So here is a patient whom I personally would not send for pre-op evaluation. My question to you, Dr. Bala, is what will be your choice of anesthesia in this patient and how will you maintain intraoperative hemodynamics?